Let's begin with our lecture, Cardiac Dysrhythmias. First, we will go over some anatomical essentials of the cardiac dysrhythmia, and then we will discuss the normal, how the conduction system of the heart work. And in this, when there is disturbance in this cardiac conduction or conduction of impulses through the heart, normal anatomical structures, then there are dysrhythmias which develop. So first, the His-Purkinje system is the bundle of His and the Purkinje fibers that leads to the conduction of electrical impulses to the different to the heart muscles, and that heart muscles then contract and create or generate the rhythm and pumps the blood out of the heart. So if any disturbance in this system or conduction in the system of the heart leads to the development of dysrhythmias or cardiac dysrhythmias. Here, if you see, that's the if we just consider these are the atria. We have upper chambers of the heart, right and left atrium, and then we have the ventricles. So these are the Purkinje fibers that comes and distribute to different heart muscles and supply the electrical impulses to the heart. So this is the SA node. If you see here, it's in the wall of the right atrium of the heart, and it's known as the SA node, sinoatrial node. This sinoatrial node is the pacemaker of the heart, the first impulse that is generated for the conduction of the impulses in the heart, that is in the SA node. So SA node is the pacemaker of the heart. When this SA node is not functioning or the impulse is not generated, usually they have implanted pacemakers that is responsible for the generation of the impulses. So SA node is the pacemaker of the heart, and the first impulse for the conduction generated in this SA node. These are the Batchman's bundle, another bundle of the fibers that is this on the left atrium side. Then from the SA node, the impulse goes to the AV node. This is the AV node, and as the name shows, it's between the atrium and the ventricle, and this is the AV node. And this is also bundle of His bundle of His. So from the SA node, the impulse which is generated goes to AV node and the bundle of the His, and this bundle of His divides into right bundle branch and left bundle branch, and this goes and gives rise to Purkinje fiber. So SA node, first step, then we have AV node between the atrium and the ventricle. From there, the bundle of His, this is the bundle of His, and this divides into we have the right bundle branch and this is the right bundle branch. So bundle of His gives right bundle branch, goes to the right ventricle, and the left bundle branch, this is the left bundle branch that gives another branches to the posterior side of the ventricle. So SA node, AV node, from the AV node, bundle of His divides into right bundle branch, left bundle branch, right bundle branch to the right side of the heart to the right ventricle, left bundle branch to the left ventricle, and also give branches which are known as left posterior bundle branches. So these are the all these are the anatomic essentials known as the His-Purkinje system, which is responsible for the conduction of the electrical impulse that is responsible for the contraction of the heart muscle. And then we have the Purkinje fibers here. You can see the right and left bundle branches. They all give here the branches, smaller branches known as the Purkinje fibers, and they are responsible for going to all the muscles of the heart and responsible for the conduction. So, SA node, things to remember: His-Purkinje system, SA node, which is the pacemaker of the heart, sino-atrial node. From the SA node, the impulse goes to AV node, atrioventricular node. Then the bundle of His divides into right bundle branch, left bundle branch, and then gives rise to Purkinje fibers, which are small fibers, you can see, that goes to all the myocardium or muscles and allows the mechanism is once the conduction or the impulse reaches the Purkinje fibers, it spread all over the myocardium and cause contraction of the heart at the same time. So the important mechanism is the heart muscles contract at the same time once the impulse reaches the Purkinje fibers. So that's, remember, when we talk about dysrhythmias, we know this is the normal conduction system of the heart. So any abnormality in this normal conduction system, which is reflected on as a cardiac cycle, the cardiac cycle, which we will talk later on the EKG, which has P wave, QRS complex, T wave, all these are, it's one cardiac cycle, and any disruption in the conduction of the impulse at any site will be reflected as the dysrhythmias, and we can observe those changes on the EKG strip also. So His-Purkinje system. Next, the ventricular repolarization. That's the cardiac cycle. That's one cardiac cycle, how it looks on the EKG strip. We can see the normal cardiac cycle. We have the depolarization phase, we have repolarization phase. Depolarization leads to the contraction. Repolarization is coming back of the action potential towards the neutral side, and that's the relaxation phase when the blood is coming back to the heart. So we have depolarization causing contraction of the heart. We have repolarization when the heart is relaxed and blood is coming back into the heart, and once it fills, then it contracts again. So it's depolarization and repolarization that constitute one cardiac cycle. So if you see, this is the P wave, we have QRS complex, T wave, and this is the T wave. So we will talk about what are the parts of the different cardiac cycle. Here, this part of the cycle is generated when the impulse comes from the SA node. So this beginning, because I already mentioned SA node is the pacemaker of the heart, so the first impulse is generated in the SA node. So first part of the cycle comes on the EKG strip is due to the impulse coming from the SA node. So any abnormality in this portion of EKG strip, we can tell there is no impulse coming from the SA node, and there is problem in the pacemaker of the heart. So this first part is due to SA node. Then we have this P wave. This is known as the P wave. This is due to atrial depolarization or atrial contraction. So P wave, any abnormality in P wave gives us the idea that this is due to any problem in the conduction of the atrium. So atrial depolarization. This part we said SA node, then atrial depolarization. This is in the AV node. After the atrium, we have AV node, which is between the atrium and the ventricle. So next part generated is the AV node. So we have SA node, depolarization of the atrium, then we have AV node. Then this QRS complex, whole Q, R, and S. These all waves, these are known as the waves of the cardiac cycle. P wave, QRS complex, it's a complex, it's the combination of three waves. Q, just going little down, that's the Q, R, and the S wave. So it's a complex of three waves, QRS, so known as QRS complex. And then this is due to the depolarization of the ventricle. Then we have the ventricular contraction after the QRS complex. This whole part is the ventricular contraction, or known as the depolarization, when the ventricle contract. Ventricle is a big muscular structure, big portion, big lower chamber of the heart. So the contraction of the ventricle, it takes the maximum space on the cardiac cycle. So all this is this QRS complex, ventricular depolarization, then we have ventricular contraction. And then this T wave is the repolarization of the ventricle. When the ventricle are repolarized, in depolarization, it's negative inside, but when it's repolarized, it comes back to the normal stage, resting phase, and in this phase, the blood comes back to the heart and it is relaxed. This T wave is due to the repolarization or relaxation of the ventricle. Now this is a very good diagram or picture giving a very clear idea of all the portions on the cardiac cycle which appears on the EKG strip. That is what are the which can tell us that it's not normal. There are problems in the conduction of the impulse and which area is affected. So SA node, atrial depolarization, this one cardiac cycle is, this whole is one cardiac cycle, which is contraction of the atria, contraction of the ventricle, and then relaxation of the ventricle. And if we run the EKG strip for 1 whole minute and count these cycles on the EKG strip, that gives us the heart rate or the pulse rate. Pulse is the heartbeat or heart rate which we can feel in the arteries of the body. So the pulse, if we do the strip for 1 minute and count these cardiac cycle, so each time the heart beats, we feel that pulse, and that is the cardiac cycle. The heart rate is roughly about from 60 to 90 beats per minute. Anything below 60 is bradycardia, anything above 90 will be the tachycardia. So that's the cycle. This is one cardiac cycle. This is the portion where nothing is happening, and then this is the portion, as you see, nothing is going on, and then again the impulse is generated, and then we will get this green interval here, and that is due to the SA node. Next, tachycardia and bradycardia. Tachycardia, as I already mentioned, tachy means fast. Cardia is heart, so the fast heart rate is the tachycardia. The average or the range of the heart rate is from the 60 to 90 beats per minute. It's beats per minute. Anything above 90 is tachycardia, anything below 60 is bradycardia, and as with anything, we have the normal average range. The average for the pulse or the heart rate is 72 beats per minute. So average means lot of people who are normal, healthy individual, if you take their pulse, that is usually in the range of 72 beats per minute. So that's the normal average pulse, but we have a broad range from 60 to 90 beats per minute. So tachycardia is fast heart rate, abnormal impulse. This is, we have the normal heartbeat. This is, we see the normal cardiac cycle. We just went over this. We have P wave, QRS complex, and T wave. This is one cycle. So 1, 2, 3, 4, 5. In this cycle, you can see these are the 5 cardiac cycles. So 5 beats so far. And then this is tachycardia. If you see in the same portion, in the same normal heart, we have 1, 2, 3, 4, 5 cycles, but in this we have 1, 2, 3, 4, 5, 6, more frequently. You can see it's coming more frequently, and the P waves are not very, they are missing the normal cycle. You see the difference between the normal cycle and this is the abnormal cycle. Even the appearance is, you can tell by the appearance. Then the bradycardia. Bradycardia is the when the impulse is generated slow from the SA node, and that's, you can see bradycardia very clearly, very slow heart rate, and the cardiac cycle is coming slowly. So that's bradycardia. Normal heart, very clear, normal cycle. P wave, QRST. Tachycardia, heart is beating fast. The whole cycle is not completing properly, and this is the bradycardia. So that's the difference between tachycardia, bradycardia. Heart is pumping or contracting fast. Impulses are generated quickly. Abnormal impulses are generated. In the other, the impulses are generated very slow. History. Now, when we talk about the examination of the patient, history of the patient is very, very important in reaching the ultimate final diagnosis of the patient. So history, what questions we need to ask to the patient in the history with dysrhythmia patient? Do you have chest pain or shortness of breath? The chest pain, shortness of breath, they usually complain of shortness of breath and chest pain because of poor pumping of the blood. They have abnormality in the rhythm of the heart. There is ischemia, decreased supply of oxygen, and that causes shortness of breath when the patient tries to get in more air. And there is also chest pain, history of chest pain. Then, do you have pacemaker or defibrillator implanted? Always ask them if they have these done. Did you feel lightheaded or dizzy or lose consciousness? Again, very important questions. You need to ask these questions in the history taking of the patient. How often do symptoms occur and when they last? Dysrhythmias, how often they occur and how long they last, that is very important for the further management of the patient, that we need to know these questions. So all these questions are important in history taking. Next, also, what else we should ask is, do you have any other medical problem like COPD? COPD, chronic obstructive pulmonary disease. Lot of people who are smokers, they have developed COPDs and they can have these issues also. So I ask the patient if they have COPD. When did your symptoms begin and are they episodic? When do the symptoms appear, under what circumstances, and whether they occur in episodes or constant? Are you taking cardiac, herbal, or any medications? Is there a family history of sudden cardiac death, cardiomyopathies, or coronary artery disease? These are all very, very important questions. We need to ask these questions in the history taking. So we should go to the proper diagnosis, and especially how we should manage this patient and what complications can occur. Have you had prior cardiac surgery? Again, that's an important question to ask. Previous history of coronary artery disease, heart failure, any dysrhythmias, if they have any previous history of these problems, and what were the circumstances under which they have these problems or dysrhythmias developed. Then the physical examination after the history, the most important is the general appearance of the patient, whether they are pale, they are sinus. These examinations are very important. So general appearance of the patient, chest pain, if they are complaining of the chest pain, or if they, in the general physical exam, you look for if they have the hand on the chest or if they are leaning forward so they can feel better. So all these, just observe the condition of the patient. If they have the chest pain, if they have hypotension, respiratory failure, and also the pulmonary edema. So we go for all these findings. Clinically unstable patients who are not stable clinically, we should go for medications, cardioversion, defibrillation, and also the pacemaker. So patients who are unstable clinically, after we do the examination, we find that the patient are not stable, they have problem. We should go for the management. Management can be done by the medications, which are anti-arrhythmic medications that control the rhythm of the heart. We can go for the cardioversion, in which the electrodes are applied, pads are applied, and electric shocks are given. Same with the defibrillation, and also the pacemakers. We can implant the pacemaker that generates the impulse when the SA node is not functioning. Impulse is generated through the pacemaker of the heart. So all these different options are available in patients who are clinically unstable. Next, what are the vital signs which help us for in the physical examination of the patient? Make sure we should know whether the patient is hypotensive or hypertensive. Hypotensive is low blood pressure, hypertension is high blood pressure. So vital signs are important. Make sure once the patient, we get the patient, we should go right away to look for the vital sign, to check the vital signs of the patient. So hypotension or hypertension. Then also compare the blood pressure. So it's important we should look and compare the blood pressure of the patient. Then the heart rate and the pulse. So vital signs are the blood pressure, then the pulse and the TPR, temperature, pulse, respiration. So blood pressure and TPR, these are the components included in the vital signs. So when we do the vital signs, we should look for the blood pressure of the patient and the temperature, pulse, and also observe the breathing of the patient, whether they are breathing normally or they have tachypnea, which is like tachycardia, fast breathing, and bradypnea, which is the slow breathing. So all these are important components of the vital signs. Skin. We should look for the changes in the skin, like the pallor. Look for the color of the skin. Patient who have dysrhythmias, or they can go into the shock or a loss of consciousness. Ultimately, they are dizzy. There is pallor of the skin, and they are sweaty, and they have very pale skin because of the poor perfusion. So look for the pallor of the skin. Then also the cyanosis. These are you can see the cyanosis is bluish discoloration, and usually the periphery, usually around the mouth, lips become blue, the fingertips become blue in color. So this bluish discoloration of the skin is known as cyanosis. Cyanosis is very important sign of the decreased supply of oxygen or poor perfusion of the tissue. So cyanosis. So look for the cyanosis also. And duskiness, these are the reddish blotches or spot, these duskiness. So all these skin findings, we should look for them if the skin is pale, if there is cyanosis, or there is duskiness. Also, when we look for the head, eyes, ear, nose, and throat should be included in the examination. Exophthalmos, look for the eyes if they are protruding out. You can see like this, exophthalmos. This is known as exophthalmos. Exo means out. Thalamus is for the eyes, of thalamus, exophthalmos. So this is common in the Graves' disease of the thyroid gland, Graves' disease. Then also look for the flaring of the nose. If the child or the patient is flaring, or this is the indication that the patient has difficulty in breathing, so they are forcefully try to breathe in, and that cause the nasal flaring. Respiratory distress. Then oral mucosal membrane assessment. Here look for the mucosal membrane, same if it's pale, that is also and also if it's dry, that's the indication of hydration status, whether the patient is hydrated or not. Then also go for the perioral cyanosis. Cyanosis is the bluish discoloration of the skin. So it's in the perioral area also. Cyanosis is indication of poor perfusion of the tissue. So as we are talking about all this, it's very important to take the proper history, and then we have so many things in physical examination. We need to look for that. We need to look for the changes in the skin, changes in the different organs, changes in the eyes, oral cavity, and throat. Then in the neck, when we examine the neck, we can look for the jugular venous pulse, level of jugular here, how the pulsation is, jugular venous pulse. Then we should press below the costal margin. Costal margin is the margin of the ribs. So we press below the costal margin and we look for the reflex. And also thyroid gland. Thyroid is the gland present in the neck, and we mentioned that Graves' disease, which causes bulging of the eyeball, is due to the thyroid problem. So when we examine the neck, we should look for the jugular pulse, press below the costal margin, and then look for the thyroid gland also. Then cardiovascular, we should inspect the chest wall. Examination of the chest wall for the PMI, the point of maximum impulse, where the heartbeat is present, maximum impulse, we should look for that. And then we auscultate, listen to the heart sounds, murmurs, rhythm with the stethoscope. And also assess the quality of pulses, evaluate capillary refill. So all these are the part of physical examination and very important to perform in patient. Also examination of the chest and lungs, which will be the look for the sternotomy scar. Look for any scar if it's present on the chest that gives the idea of any previous surgeries performed on the heart. So if we have sternotomy, opening in the sternum, which is the breastbone, that gives us the idea that there was previous surgery performed. Inspect for the accessory muscles. Accessory muscles are used, muscles between the ribs. They are used for the breathing. So look for the accessory muscles. Pulmonary rales or wheezing. Listen for the sounds, wheezing, which is due to volume overload and left ventricular failure. And percuss the chest wall. Percussion is the when you put the hand on the chest and tap it with the finger, that produces the sound. If there is air in the chest, it produces resonant sound. If there is fluid, it produces dull sound. So percussion also give us the idea if there is fluid in the chest or if there is volume overload. So all these examinations, we talked about the history taking, we talk about the general appearance of the patient, look for the color of the skin, look for the appearance of the patient, and then we go for the different organs, different systems one by one that help us in the diagnosis. Next, some radiologic studies of the patient on the X-ray, portable chest X-ray. We can evaluate the cardiac silhouette, assess for any pulmonary vascular congestion if it's present, Confirm appropriate placement of pacemaker, if there was pacemaker placed, if that is properly placed or it's appropriate, and also the placement of defibrillator leads. So all these are important findings on the chest X-ray. Then some lab studies we need to do is we will be like cardiac enzyme studies, which include CKMB and troponin 1. Thyroid function test, serum thyroid stimulating hormone levels. Then we go for some drug levels like digoxin, and also the electrolytes like serum electrolyte panel we start, which gives us the idea of all the different electrolytes. So these are some lab tests we should do on a patient with the cardiac dysrhythmias. We should do cardiac enzyme level, thyroid function test, drugs like digoxin level, and also the study of the serum electrolytes and serum magnesium and potassium level. Then we will talk about the management of some bradydysrhythmias, specifically bradydysrhythmias. Bradydysrhythmias are the slow rhythm of the heart when the impulse is generated very slowly from the SA node, causes bradydysrhythmias. So adult bradycardia with pulse, we have assessed the appropriateness for clinical condition if the heart rate is less than 50 per minute. So I mentioned that the normal range is 60 to 90. Anything below 60 will be labeled as bradycardia. In this, the pulse is very slow. It's even less than 50. So less than 50 per minute. Then identify and treat underlying cause of the bradyarrhythmia, maintain the airway, take the 12-lead ECG and give the IV access to the patient. So if there is the bradycardia, we identify the underlying cause and then maintain the proper airway. That is important. Put the EKG leads on the chest, so we should get the constant recording of the heart activity, and IV access should be given for the management or medications. If there is persistent bradyarrhythmia and there is hypotension, low blood pressure, signs of shock present, if there is ischemic chest discomfort, acute heart failure. So if there is sign of all these complications, then we should give the drug known as atropine. If atropine is ineffective, then we should go for transcutaneous pacing, dopamine, or epinephrine infusion. If these findings are not present, we should just observe and monitor the patient. So just follow up the patient and observe the patient for a while. But if there are signs of hypotension and there are signs of shock or any heart failure, we should start the medications. Consider expert consultation and transverse pacing. Sinus bradycardia was the management of sinus bradycardia discontinue negatively chronotropic medications. Lot of people, they have a normal sinus bradycardia, they have little low heart rate. Usually the athletes, people who work out regularly, they have sinus bradycardia, means their heart rate is slower than the normal. So sinus bradycardia, then we should discontinue any negatively chronotropic medications. Administration of reversal agents like IV glucagon, and permanent pacemaker is also indicated. Sinoatrial block, SA block. That's the EKG strip of the patient who have sinoatrial block, means the impulse is not generating or transferring through the sinoatrial nodes. There is sinoatrial block, and you can see there is no regular transmission. There is no interval that is generated by the SA node. So that's the appearance of the EKG with the SA node block. Management of SA node block is, if there is SA node block, what happens? Sinus exit block. So there is absence of atrial depolarization. We know now the normal cardiac cycle. When the impulse from the SA node reaches the atria, it causes contraction of the atrium or atrial depolarization. So when no impulse is generated and there is block in the SA node, the pacemaker is not functioning, then there is no atrial depolarization, there is no proper generation of the P wave. SA nodes failure to generate the impulse, failure of SA node to conduct to atria. Alternate region of myocardium becomes dominant pacemaker. Now the SA node is not functioning, so some other alternate area, some other portion of the myocardium will start generating the impulse, and that impulse is not the same impulse or the right impulse or the proper impulse generated by the SA node. So there is development of the dysrhythmias. Treatment is based on patient symptoms. What are the symptoms patient is presenting? Then we manage according to that. Then another condition known as sick sinus syndrome. Sick sinus syndrome, the management of the sick sinus syndrome, there are different conditions that cause or affect the SA node, and this is sick sinus syndrome. If patient has bradycardia with sick sinus syndrome, we augmentation of rate, we give the atropine. Atropine increase the heart rate. If patient has tachydysrhythmia or tachycardia or tachydysrhythmias, we should give the beta blockers, calcium channel blockers, and digoxin is the treatment. So sick sinus syndrome, depending on whether the patient has bradyrhythmia, dysrhythmias, or tachydysrhythmias, or bradycardia or tachycardia, we treat the patient accordingly. Then we have, after the conditions of SA node or abnormalities of the SA node, SA block or sick sinus syndrome, then the impulse reaches the AV node. So the next site where the problems can originate are the AV node problems, and if the impulse is not generated or transmitted through the AV node, and this is also known as like SA node block, the AV node block. So first degree AV node block. The first degree AV node block is not very serious. Sometimes if the patient is asymptomatic, they don't need the treatment. So, but as it progresses and becomes second degree, then further management is done. So first degree atrioventricular block. Evaluate and treat the causes. Asymptomatic, no treatment needed. So unless the symptoms develop or problems develop, we don't need any treatment. So asymptomatic, no specific treatment unless we have some conditions which can cause this problem. If there is bacterial endocarditis, abscess present, or if AV block worsens, we use the temporary pacemaker. And if there is rheumatic fever also that affects the node, then we should also look for the worsening of the AV block and then manage it. If there is acute myocardial infarction, no therapy usually is required. So depending on the symptoms of the patient or the condition of the patient, if the patient is asymptomatic, we don't need any treatment for the first degree AV block unless there are certain conditions present in which we sometimes need temporary pacemaker or just observe the patient unless there are symptoms develop. Then if the patient considered drugs used to treat MI, myocardial infarction like beta blockers. If their patient is symptomatic, if there are symptoms associated with first degree AV block, then if PR interval which is generated by the AV node. If you remember your first slide when I talked about the normal cardiac cycle, the PR interval, the interval between the P wave and the beginning of the R wave is the PR interval that is caused by the AV node. So if that is prolonged, AV pacing is done. Consider permanent pacemaker for hemodynamic stabilization. Next, if there is second degree AV block, if there is a partial block, this is the picture that shows the partial block, not complete block. That's the second degree AV block. And usually we have the QRS complex absent in some cycles. You can see we have P wave, no QRS, then P wave, there is QRS complex. So there is a partial block, there is no QRS complex is forming. And why it's not forming? Because the impulse is not reaching from the AV node to the ventricles, and because it's a partial block, not the complete block, so some impulses reach, some don't. So some areas you see the QRS complex, in some areas it's absent. Second degree AV block, we have type 1 and type 2. That's the type 1 AV block. The management of type 1 AV block is the temporary pacemaker to bring the rhythm to normal. Type 2 second degree AV block, that's the EKG appearance of type 2 AV block, and the management of this is the permanent pacemaker. So we have temporary pacemaker, and because it's a little milder than second type, we have the permanent pacemaker. Even the EKG strip tells you that the cycles are this is the dysrhythmia present. Then we have third degree AV block. First degree AV block, we mention if the symptoms present, then only we treat it. Second degree is more we treat it by the temporary pacemaker or the permanent pacemaker. And then we have the third degree AV block, or more like a complete block. It can be very serious, and that's the strip appearance of the dysrhythmias that is due to the third degree AV block. Third degree AV block, the management of third degree is depend on the status of the patient. Reversal of drugs causing AV nodal block. Some drugs also cause the nodal block. If that's the case, we should stop using those drugs. If hemodynamically patient is compromised, then we should use transcutaneous or transvenous pacemaker. If irreversible underlying cause is present, then we should use permanent pacemaker. So all these are the management options for the patient with the third degree AV block. Next, the tachydysrhythmias. If tachydysrhythmias or fast dysrhythmias are present, how we manage them? Again, the heart rate, if in this case more than 150, very bad tachycardia, more than 150. Then we should again same identify the cause and treat the patient, put the cardiac monitor, give the oxygen, maintain the airway. With such a fast heart rate, the pumping is not proper, but blood is not pumping out, oxygen supply is poor, so we should maintain all these things. If look for again signs of any hypotension, shock, if there is acute heart failure or ischemic chest discomfort present, then we should go for cardioversion, sedation, regular narrow complex. If not, look for the QRS. If it's wide QRS, which means more than 0.12 seconds, we should go for the IV access and put the EKG strip. Adenosine and any antiarrhythmic infusion is given and expert consultation is done. So finally, if no, then we need to go for IV access and then 12 lead EKGs. So make sure EKG and ECG, they are the same thing. So sometimes it's electrocardiogram ECG, but in America and other countries, usually they mention it as EKG also. So it's the same thing. Then we have sinus tachycardia. Sinus tachycardia, again sinus arrhythmia, sinus bradycardia, sinus tachycardia is the tachycardia which is from the SA node. So that's the picture of sinus tachycardia. You can see a very fast heart rate, but the cycle is pretty much the normal, but it's fast. So the sinus tachycardia, the management, P wave precedes each QRS complex. So there is normal cycle, the P waves are present before each QRS complex. If due to acute myocardial ischemia, beta blockers are given to treat the sinus tachycardia. And if uniform morphology and constant PR interval. So sinus tachycardia, again, like sinus bradycardia, can be in the normal individuals depending on how fast this sinus rhythm is generated, and if the cardiac cycle is normal, each QRS is preceded by P wave, there is normal constant PR interval. So the findings are almost the same as the normal EKG. Then we have another condition known as paroxysmal atrial tachycardia. Paroxysmal means occurring in episodes, episodic type of tachycardia, paroxysmal atrial tachycardia, PAT. So that's again the appearance of the EKG with the paroxysmal atrial tachycardia. Some areas you see it's not, it's infrequent, not very, it's in the episode. Here it's different. Then we have normal cardiac cycle, P wave, QRST, PQRST. So this is the normal cycle. This is paroxysmal atrial tachycardia. So it's occur in the episodes. Then atrioventricular node reentrant tachycardia. This is another condition, ANRT, atrioventricular nodal reentrant. So in this, the impulse, it is re-entered and then cause this type of dysrhythmia. So ANRT, this is the normal sinus rhythm. The normal rhythm is the fast and slow component like this. So this is the normal rhythm. Then we have the common AV and RT rhythm. How this common AV and RT rhythm present, it has first the slow component, then the fast. This is another common type of re-entrant tachycardia. So normal sinus rhythm, we have fast and then the slow component. In common AV and RT, we have the slow rhythm first, then the fast, and then finally the uncommon AV and RT. Again, we have first the fast, then the slow. But the slow is not, it goes all the way up, and very, very small portion of the slow, that's the uncommon type of AV and RT. These are the appearances on the EKG. With the common type, we have only, here you can see, and then we have the uncommon type of the AV and RT. The management of this condition, if the patient is symptomatic, if the patient has symptom, we should go for ablation. Usually the patient prefer ablation. Slow pathway catheter ablation, or we should go for beta blockers, verapamil, diltiazem, which are the calcium channel blockers. We should go for these type of antiarrhythmic drugs. So catheter ablation can be tried, and the drugs can also be tried. Flecainide or propafenone, and then we have a myodron, digoxin, and sotalol. So all these drugs can be tried. Then if these drugs don't work, then we should consider again for the catheter ablation. If no symptoms or only minimally symptomatic, then we should follow up the patient without the treatment. Again, atrioventricular re-entrant tachycardia, just few terms used in this condition depending on how the impulse or the action potential goes and how it comes back. Re-entry means it again enters and generate the impulse. So this is the sinus rhythm. From the SA node, that's the normal sinus rhythm. It goes to AV node, and then from there it goes to the ventricle. Again, we have bundle of His, and then right bundle branch, left bundle branch, which goes to the ventricle and Purkinje fibers. In the sinus re-entrant type of tachycardia, you can see that's the type of cycle or appearance which is on the EKG, you can see. Again, sinus rhythm, we have AP action potential that goes in this direction. So it's the normal direction. The other condition is orthodromic AVRT. Here, this is the normal conduction, and in the sinus rhythm, re-entrant tachycardia, you can see it's little on the side. So that's why the QRS complex that's generated, you can see it's little tilted to the side because of the re-entrant phenomena. Then we have another orthodromic type. Orthodromic, you can see here the impulse goes back in the direction and again comes down. So it's re-entering in the back direction. Orthodromic AVRT. And then we have antidromic. So it goes in the backward direction. So in this, it comes through the ventricle and goes back, and in this it goes backward and comes. These are the few types of re-entrant tachycardias that develop, and these are the appearances on the EKG of the cardiac cycle. We have this a change in the QRS complex. Then we have here after the QRS complex, before the wave, we have small wave generated there because of the orthodromic. And again here we have, you can see all different, no normal cycle is present, and these are the P waves present because the cycle is all in the opposite direction. Next, atrial fibrillation is the another condition in the atria is fibrillating, or the contraction is not normal. This is the right atrium, again SA node. Then we have AV node and the left atrium. Then the atrial fibrillation, what's the management of atrial fibrillation? Atrial fibrillation is the condition when the atrium, the rhythm is not, an atrium is just flickering or quivering. So the contraction is not normal and the pumping is not normal. So quivering of the atrium, or it's fibrillating. And the condition very common, the impulse generated, if you take the pulse and the pulse is irregular, very significant of atrial fibrillations, pulse is irregular. Our pulse, when we take it, it can be regularly irregular, or it can be irregularly irregular. 2 beats, we have pause, then we have 3 beats, pause. So it's all irregular. That's atrial fibrillation. And patient with atrial fibrillation, they can send the clots and they can have the strokes also because of this problem. So management of atrial fibrillation, that's the patient with the atrial fibrillation. You can see waves, P waves are very here not in the regular rhythm. So atrial fibrillation. Management is, a patient is unstable, look for the heart rate. If more than 150, do the cardioversion. If less than 150, look for and treat underlying cause. If sinus rhythm, again, we should look and identify the underlying cause. If not, then we should control the blood pressure, phenylephrine 50 to 200 microgram intravenous fast pushed in. Control the heart rate, diltiazem is used for that, 5 to 10 milligram intravenously, again push. Atrial fibrillation, again, if the patient is clinically stable, then we should go give beta blockers, calcium channel blockers, and digoxin. Few very, very important drugs. We have beta blockers, calcium channel blockers, digoxin. They control the rhythm, blood pressure, and can be used in the stable patient. Atrial flutter is another condition, again very, very bad. You can see there is no normal rhythm, all dysrhythmias, P waves are not, QRS complexes are not normal. So it's the atrial flutter. Management, again, is cardioversion is done, pads placed on the chest and back, electric shock is given to bring the rhythm back to normal. This is the cardioversion machine. Multifocal atrial tachycardia, treating chronic lung disease. Patient who have chronic lung disease, treating chronic lung disease, they can have multifocal, different foci generating tachycardias, calcium channel blockers. Ventricular tachycardia, you can see ventricular tachycardia. And we have monomorphic, same pattern. You can see it's the same pattern, and polymorphic, different patterns are showing up on the EKG. Management of ventricular tachycardia is unstable patient. We should go for immediate cardioversion. Ventricular fibrillation with immediate defibrillation. Stable patients, IV antiarrhythmic medications and serum electrolytes should be drawn in all patients. Hypokalemia and hypomagnesemia to be corrected. SVT, which is supraventricular tachycardia with aberrant conduction. This is the EKG strip appearance of the patient with aberrant conduction. An unstable patient, they should be treated with the cardioversion. Then another condition known as torsades de pointes. The management of this is interrupt the rhythm, restore sinus rhythm. Electrolyte abnormalities should be corrected. IV isoproterenol and magnesium sulfate should be given. Also, cardioversion also should be done. Atrial fibrillation with pre-excitation. Again, this is another condition in which we should, if the patient is stable, we should give IV procainamide. Chemically cardiovert patient to sinus rhythm without slowing conduction through AV node. Unstable patients, synchronized electrical cardioversion and radiofrequency catheter ablation of bypass tract. accelerated idioventricular rhythm, that's accelerated idioventricular rhythm. So that concludes our topic of cardiac dysrhythmias, in which we talked in detail about all the dysrhythmias of the heart and how we can manage it. If I summarize the management of the cardiac dysrhythmias, of all the dysrhythmias, the summary is depending on the condition of the patient. If the patient is unstable or stable, if the patient is stable, we have time for management. We should go for medical treatment. If asymptomatic also, we should look and observe. But if the condition of the patient is not stable, then we should go for more aggressive management, which is defibrillation, cardioversion, and in some conditions, permanent pacemakers should be implanted. So that was all about our today's topic, cardiac dysrhythmias. Thanks for watching sqadia.com.